Hello, everyone. I'm Leonel August Rodriguez, the VP of Business Development for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insight from leading medical experts. We do ask that all questions are submitted via the Q&A, as they will be answered at the end of the presentation. So today, our special guest will be speaking on a very simple solution to weight loss success and overall better health. He is a board-certified family practice physician, certified in age management medicine, and is the founder of the research clinic in Texas. Without further ado, Dr. Kris Wusterhausen.
Thanks, Leo. I appreciate that great intro. Hi, everyone that's listening tonight, and anyone maybe even listening in the future with this video recorded possibly. So I'm Dr. Kris Wusterhausen. Everybody calls me Dr. Kris. I am a board-certified family physician, but about 12, 13, 14 years ago, I transitioned my practice over to a cash-based age management medicine practice. Really started with hormones, some aesthetic procedures, and have grown my practice from there. And currently we have a clinic outside of Dallas-Fort Worth in Weatherford, Texas, just west of Fort Worth. And we actually just opened Nashville, Tennessee in the last month. And you can see my websites there, my Instagram, if anybody has any interest in that. So one of the most common complaints, and I'm sure that other providers can agree with me on this, is patients coming in who are overweight, who are wanting to lose weight, who are fatigued. It's one of the biggest headaches as a practitioner that I used to deal with and still deal with, but I feel like I have a much better approach to treating these patients. And so, I used to use all the traditional modalities like phentermine or telling my patients, you just got to eat less, exercise more, and I had very limited success. And so as I got into hormones, and I did that for quite a few years, I found a modality which was peptides. And for anybody that doesn't know what peptides are basically chained amino acids. I like to tell my patients they're signaling agents, basically signaling the body to do a function. And we have over 7,000 peptides in our body. The most common one that we all know is insulin. And so I started using peptides in my practice, and that's when I really started to get a better grasp on helping patients get to that healthy metabolism, healthy weight, but doing it, I believe, in a very safe, effective manner. So why does metabolism matter? And some of this is going to be very simple, but I like to put it in there just so that we trigger these thoughts. We know that metabolic dysregulation is at the core of the most common causes of death. We know that, atherosclerotic or heart disease, cancer, neurodegenerative disease, we know that this metabolic dysregulation is really what's starting this whole process. And I just threw some different stats in here because, again, I think we all know as providers that obesity and diabetes makes us much higher risks for pretty much everything. But I think it's good numbers to know. If we're diabetic, we're 2 to 4 times more likely to develop heart disease. We're 2 times more likely to develop certain cancers, and we're 65% higher risk of Alzheimer's disease. Alzheimer's disease is something I really go after in my practice. I want to make sure my patients know that 40% of Alzheimer's disease prevention is in their hands, and blood sugar control is a very important part of that. If you're obese, you're 2.5 times more likely to develop heart disease, 7 times more likely to develop certain cancers, and 39% more likely to developing dementia. Staggering stats. So I just threw in here to remember about metabolic syndrome, because I think that a lot of our patients fit the criteria of metabolic syndrome, but sometimes we just aren't thinking about that, because really the criteria is not very hard to meet for some of our patients, so it's that expanding waist circumference, 40 in men and 35 inches in females. Triglycerides over 150, HDLs under 40 in men and under 50 in women. And then I love the fasting glucose. I think it's such a cheap, easy test to look at. You can really predict some of these things down the road by just looking at that fasting glucose. I try to keep my patients' fasting glucose under 90. I personally use a continuous glucose monitoring system. I promote that with my patients. And then also looking at their blood pressures, over 130, over 85, criteria for metabolic syndrome. So I think we're going to find a lot of our patients are metabolic syndrome, but we just don't really think of them that way because they're not that overweight and we're just not always thinking forward. So insulin resistance, it's a term that I always use with my patients and providers that I train. I think it's important. Some of the tips about insulin resistance is to realize that most of your insulin resistance actually starts in the muscle. So we know that insulin signals muscle, fat, liver to uptake that glucose, to move that glucose from the blood into the cells. It also tells the liver we've got enough. We don't need to make more glucose. And so insulin resistance is an impairment in any part of that system. We have insulin resistance. And so this is a progressive problem. You start with insulin resistance and you start with too much insulin, and then eventually that system breaks, and now we have glucose rising, which leads to fatty liver disease, NASH, and then ultimately type 2 diabetes. So progression goes from, of course, the insulin resistance in the muscle, then it leads to insulin resistance in the liver, and then ultimately our patients end up with full-blown diabetes type 2. So again, in my practice, we're always harping on the skeletal muscle. So that's something that if you're my patient, you know that I'm always talking about muscle mass, preventing sarcopenia. By the way, insulin resistance, we know it starts in the muscle. When insulin resistance goes up, myostatin in the muscle goes down. Myostatin actually, when insulin resistance goes up, the myostatin goes up and starts creating a breakdown of the muscle mass, which then ultimately leads to sarcopenia. And we know that our sarcopenic patients, become frail as they come older, because that's what sarcopenia is. But when we're looking at the skeletal muscle and insulin resistance and metabolic syndrome, we see that the muscle simply can't store as much glycogen, which then triggers more de novo lipogenesis, which leads to the lipid dyslipidemia, which ultimately leads to fatty liver disease, NASH, and then again diabetes. So when we look at the change in muscle versus the liver with glycogen storage, we see that when you look at these slides on the left, you can see that in our insulin sensitive patients versus our insulin resistance, we have a 60% decreased amount of the ability to store glycogen in the muscle. But in the liver early on, it actually remains fairly static, a slight decrease, but not much. And this is just really trying to show how the muscle is where this problem starts. We then can look at how it affects the liver fat and the hepatic de novo lipogenesis. And again, in these insulin sensitive patients versus resistance, we will notice a 2.3 times amount of liver fat accumulation in those insulin resistance patients, and then also a 2.2 times increase in those liver insulin resistance patients in the de novo lipogenesis. And when this happens, that leads to this increased accumulation of liver fatty liver, but then also increases our VLDL, our triglyceride levels, but at the same time reducing the good cholesterol, the HDL. So I just like to show these slides to kind of see the progressive aspect of how hyperinsulinemia ultimately affects our patients. So who needs metabolic optimization? Well, really, it's most of our patients. We know that 2/3 of Americans are either overweight or actually obese. We know that 47 million Americans currently, or 1 in 6, actually meet the criteria of metabolic syndrome. That's why I think that as practitioners, we're so busy and sometimes we miss who actually has metabolic syndrome. 96 million Americans are actually pre-diabetic, 1 in 3. I think these are staggering figures. So when providers say, well, who should I be looking for this in? Well, really, anybody that's overweight, we need to be looking at this. And so what are early signs of insulin resistance? resistance. I love just a simple fasting insulin. It's a great way of looking at these patients. The fasting blood sugar, fasting insulin, insulin levels greater than 8 is a great way to start screening these patients. So when these patients come in my door, what are they typically looking for? What are their complaints? And I always say it always starts as, doc, I just don't feel good. I don't have enough energy. And oh, by the way, I've been gaining weight over the last 10 years. And, I've ended up 40 pounds overweight. I'm not sure how it happened. How can you help me? But I think it's really important that we dig a little deeper. And when we find, because I think it's always important to know what my patient's goals are. I document those goals so I know what they are so that I help them achieve their goals. And secondary reasons for these visits is our patients are wanting to sleep better. They're wanting to have a better sex life, because when we feel better, typically that improves. They want to improve their brain function. Most of these patients they feel like they're past their prime. They want to, of course, look in the mirror and look at a person that they like more. They want their body composition to be better. And ultimately, we have to look at their gut. And in the parameters of this 20, 30-minute lecture, I don't have time to go over it, but gut health is extremely important and should not be skipped in these patients. Most of these patients have very poor overall gut health, and we must make sure that we're recognizing that and doing our best to help them with their overall gut health. So treatment goals, again, these are the goals that I look for in my patients. Of course, I'm trying to meet their goals as long as they're reasonable, but I want to improve their body composition metrics. By the way, in my practice, we have an InBody 570. I think that if you're going to truly do body composition in your practice and really do a successful weight loss program, you have to have an objective way of measuring their progress. And for me, that's the InBody 570, because I can measure their body fat percentage, their muscle mass, and their visceral fat. Because as I always tell my patients, I've done you no good if I cause you to lose 15 pounds, but half of that was muscle. Again, remembering I need to maintain healthy muscle. I need muscle mass so that they don't become sarcopenic. Visceral fat, so crucial. The InBody 570 measures visceral fat. And that is, the fat around our organs that is so inflammatory, leading to all these chronic diseases. And when I can get my patient's visceral fat under 8, I know that for a fact that I have dramatically improved their long-term health. I want to make sure I'm improving cardiovascular risk factors. I don't want to look at different exercise capacity. I want to make sure we're doing nutritional counseling. I'm a big fasting person, so I always recommend fasting to my patients. I'm a big fan of 16-8, at least 4 to 5 times a week. Nothing but water, black coffee, unsweet tea, 16 hours a day, continuous feeding for 8 hours a day. My patients who fast get better results from what we're about to talk about. And I want to address their sleep and stress management, making sure that that's being taken care of properly. So when I look at my patients, of course, I want a nutrition and exercise history. I want to know basically what your activity level look like. What are you doing for activity? How do you eat? What's your best day? What's your worst day? Kind of give me a real idea of what you do. And I always try to tell my patients my faults with eating so that I give them the feeling like, hey, he's not perfect either. And I feel comfortable really sharing how I eat, because as we know, sometimes our patients don't always tell the truth. I want to look at their body composition metrics with the InBody 570, and I do want some basic labs. So what labs do I do? So this is something that your lab panel can be huge or it can be very small. I think that this is totally up to you and your practice. I always say it depends on your patient's budgets. In Texas, I'm a little more rural. My patients don't have quite the budgets. In Nashville, bigger budgets. I think they can afford more. I like more labs. But I don't think it's always necessary for what I'm trying to do here. I want a basic CBC. I want to make sure that they're not anemic, that they don't have, some sort of highly abnormal white blood cell count. I want to look at that CMP and see what their fasting blood sugar is. I want to make sure their renal function and liver function is normal. For me, I like to do hormone labs and thyroid labs. Again, those are different for everybody. The purpose of this lecture is not to go into what I think are important hormone labs. Every hormone doctor does it a little bit differently. I want to look at that A1C. I want to see, are they already showing levels of pre-diabetic? What stage are we here? What's their fasting insulin? For me, I at least need a CBC CMP fasting insulin and A1C, but I really like a lipid panel, CRP, uric acid, homocysteine, looking at those inflammatory markers, ApoB, go on my lipid panel, look at my cardiovascular risk, IGF-1, because I do a lot of peptides and I like to look at the insulin growth factor 1. Again, set that baseline. I want to look at these labs. And if they are abnormal, one of the questions I get asked is how often to repeat the labs? Well, that's variable. If I have a patient whose labs overall look pretty good and they just need to lose weight, they really aren't that hyperinsulinemic, their A1C is normal, I may not repeat the labs for 6 months. If I've got someone whose A1C is a little elevated, or their insulin levels 35, their fasting sugar is 105, I like to repeat it in 3 months after they've lost some weight so I can show them how good they're doing. That just reinforces the program that this is working. This is objective data that's working for my patients, and that only gets them to buy into my program more. So I just put in, kind of what I'm looking for, again, that fasting insulin under 8, visceral fat under 8, some different parameters there, blood pressure normalization. These slides will be there for you. So what do I use mainly? I use the peptide semaglutide. Semaglutide brand name is Ozempic. Many of you practitioners, maybe you already use semaglutide for weight loss. Maybe you're using Ozempic for diabetic control. Maybe you're using Ozempic for weight loss. Ozempic, semaglutide, let's talk about Ozempic. Great product, brand name product, can be difficult to get into your patient's hands at times. Now that we have semaglutide compounded, it's a much more affordable version, also has a multitude of dosing abilities, whereas with the pen, we have predetermined amounts that we can inject. Ozempic, I looked it up today in my area, a prescription of Ozempic, at the local pharmacy is $950. So certainly if you're uncontrolled diabetic, some of your patients can actually get semaglutide as Ozempic for just their copay. What is it doing though? What is it? Well, it's a GLP-1 agonist, a glucagon-like peptide 1 agonist. Originally, GLP-1 agonists were found in the saliva of the Gila monster, which I think is really kind of cool. And they originally saw that it had a great effect on blood sugar control. And because of the billion-dollar industry that is diabetes, that's where Ozempic went after that market and all the GLP-1s, Victoza, the other ones, of going after the diabetic market. But what we know with it is, what I tell my patients is, it works on the hypothalamus of the brain. It's an amazing peptide because it decreases your appetite, but at the same time increases your fullness. But it also cuts down on those cravings and just eating for no reason, which I think is what is amazing. My patients who drink don't drink as much. My patients who love sugar, and that would be me, when I'm on my semaglutide, I just realize I don't have those cravings for it. And a lot of that is through serotonin receptor stimulation. So I just put this in here, it's a GLP receptor agonist, which promotes skeletal muscle. Again, back to that skeletal muscle. That's why I put those first few slides in there. It's improving that skeletal muscle glucose transport by triggering AMPK signaling, and then ultimately GLUT4 activation, which is translocating the glucose to the plasma membrane and into the cell. So basically, we're making that dysfunctional system now functional in these insulin resistant patients. And I do find, as a tip, my diabetics don't lose weight as fast as my hyperinsulinemic patients. My hyperinsulinemic patients don't lose weight as fast as my non-hyperinsulinemic patients. So that's always important into guiding my patients on how long this is going to take for them to lose weight. So why semaglutide? Quickly, we'll run through this. This was actually a 104-week study, and I just wanted to put it in here and I believe I actually see a little bit better results than this, but because I'm using it for straight weight loss. But they saw a 9.2 centimeter reduction in waist circumference versus placebo, systolic, a 4 millimeter difference, diastolic 3.7 millimeter of mercury difference besides placebo. C-reactive protein reduced 53% versus placebo. A1C reduced about 0.33%. Fasting sugar, though, reduced 9.2 milligrams per deciliter. This is the one I really like. The fastum serum insulin actually reduced 27% versus placebo, and triglycerides also reduced 22% versus placebo. So all that lipid dysregulation, hyperinsulinemia, blood sugar control is all getting better when we're using our semaglutide. Now, for those out there that's not comfortable with Ozempic/semaglutide, remember, it will not make you hypoglycemic. It only works on high insulin, high sugar. It will not bring your blood sugar down. So if you're in normal range, you don't have to worry about your non-diabetic patients, or even your diabetic patients becoming hypoglycemic, at least not from semaglutide. So here's the most important part. When you use semaglutide, the dosing is the most important part. You must start low and go slow. All right, low and slow. It's the key. You will lose patients if you go too fast. They will get side effects. The biggest side effects of semaglutide are GI related: nausea, reflux, constipation, some fatigue, okay? But mainly nausea, constipation, reflux. Those are your three main side effects. And the nausea, by the way, so this is a once a week injection. So if they have side effects, it's going to be off and on for a week. It's not just going to be for a couple hours. So you will minimize / not have these side effects if you start low and go slow. We never, and I stress the word never, increase our doses any more frequently than every 2 weeks. Typically once a month we increase the dose, okay? We always start out at 0.25 milligrams and we go up at a clip of 1/4 milligram at a time. And you can see based on this, the pharmacy that I use is 2 milligrams per ml. You have to adjust your dosing if the concentration at your pharmacy, compound pharmacy, is different. Remember that. So what are some of my tricks that I like to do with this that I tell providers? Because I've been using semaglutide very actively for well over a year. And again, don't skip titrations. Don't say, well, this patient weighs 300 pounds, so I'm going to go ahead and jump to the 3rd dose. No, we're going to start low. We're going to start at 0.25. We're going to do that for at least 2 to 4 weeks. So follow them up frequently for the first month. See them at least once every 1 to 2 weeks. That can even be with one of your assistants, like a medical assistant or a nurse. Have a pre-filled out form for them to answer. Are you having any nausea, constipation, reflux, fatigue? Nope, nope, nope. Okay. Are you getting that? I tell my patients I want to see a 50% reduction in their appetite. I want them to be fasting. It's now 12 o'clock. They're still saying, I'm not very hungry, but I know I need to eat. When they eat, they feel full very quickly. That is the dose. We do not need to go up from there. Okay. The only time I go up is if that effect wears off, which actually doesn't happen as much as you think. Many times these patients will respond to the 2nd, 3rd, 4th dose. Really, I put in here 0.5 to 1.5 is the best results. I think really, if I had to narrow that down, 0.5 to 1.25 is where I see most of my patients ending up. So not real high doses, okay? And there's sometimes this thought, well, doc, I'm just going to keep going up on my dose because I'm going to lose weight faster. The goal is not to lose weight too fast, because when you do, you're going to start losing muscle. I do not want my patients to lose any more than 10% muscle. So if they lose 20 pounds, I'm only okay with 2 pounds of muscle or less lost in that time frame, preferably 5%. Okay. So side effects. Sometimes patients still say, despite slow titration, I have a few side effects. So some things I tell them to talk to. So if your patient says, I really only noticed my side effects the first 3 days after my injection. So I take my shot on Monday, Tuesday, Wednesday, I'm pretty nauseous or reflux, but Thursday through Sunday, I'm okay. Many times the dose will actually last more like 10 days in these patients. So move that patient to every 10 days instead of every 7. It's kind of a 7 to 10 day shot. Also, sometimes if they really have a lot of side effects all the way through, I'll split the dose. I'll do, say they're 0.5 milligram is their dose. I'll do 0.25 milligrams on Monday, 0.25 milligrams like on Thursday, Friday. That is a nice also way out there. I know practitioners, that's how they always do it. I just think that if we can get away with once a day, that's a little better just for compliance sake. Make sure your patients understand that we're all going to try to overeat at times, even though our body feels full. And by the way, patients don't feel like they're suffering through this. I always tell my patients, how do most of us try to lose weight? We try to lose weight by not eating, but we find ourselves hungry an hour later. We're digging in the pantry, grabbing ho-hos and snack cakes because we're hungry. Patients on semaglutide do not feel like they're missing out on anything because they're full. But warn them, if you overeat, you're going to pay for it. It's kind of like you've ever ate really clean for 2 weeks and then had a cheeseburger and fries, and how you ended up in the bathroom for probably a little while. Make sure they understand this. Make sure that even though they're not hungry, they're eating nutrient dense food. That's why the InBody 570 is really important in my practice, because I want to monitor that muscle. If I see somebody that's losing more than 10% muscle, there may either be on too high of a dose of semaglutide, or they're not eating enough protein, nutrient dense food. They're having a side salad instead of a smaller amount of a protein source on a salad. So make sure that they do that. Make sure they understand that if they do fast, if they calorie restrict, they're going to lose weight faster. My patients who fast, as I said earlier, absolutely lose weight faster. Studies actually show with semaglutide that over a year, most patients lose on average of 15% in their body weight. We do better than that, but I think that's because we add in all these tips. In the study, they got very minimal nutritional consultation. And so I always try to pair it with fasting, but I also try to work on their exercise, make sure they're exercising properly. Exercise doesn't have to be crazy. These patients can simply do, I like zone 2 metabolism. Now in our office, we use a device called the PNOE, which actually can truly test through your carbon dioxide exchange, your actual zone 1, 2, 3, 4 of metabolism. But zone 2 is actually lower heart rate than most people think. Most patients, it's about 105 to 115. So I tell my patients, if nothing else, get a heart rate monitor and go walk 3 times a week, 30 minutes, keeping your heart rate around 110 beats per minute. Zone 2 is where we get our best fatty acid metabolism. And so we don't have to have these patients doing a whole lot of exercise to lose fat. And that's the goal of what we're trying to do here, to make these patients healthier. So, and again, that can be done so easily. So I hope that was informative. I know it was a lot of information that I packed into a short amount of time. With the time restraints, that was about what I could get in. So I'm welcome to try to answer any questions if there happen to be any.
Dr. Kris, amazing presentation, super helpful. I took a few notes for myself. I wanted to thank you once again for joining us tonight.
Thank you.
It's a pleasure, sir. And to all of our viewers, again, I don't see any questions in the Q&A, but if you do have any questions, please send us an email to learnmore@accessmetlab.com. And I spoke too soon, Dr. Kris. We have a question in the Q&A that just popped up.
All right, what do we got?
So the question is, what if insulin level is below number? ?
Say the last part again, is below what?
Is below number. I'm not sure if you understand that.
So maybe they mean like optimal, like it is below 8 already. I'm thinking what they mean by that is that the insulin's not high. That's actually, those patients are going to react faster and have results quicker. And so for me, I'm using those labs, because I want to see where they're at. I want to see what risk they are of developing diabetes, but I also want to show them I can return that to normal. But I also want to give, and actually, you know what? I didn't cover it in the webinar, and I think that's a great topic real quick, is expectations and goals. And so if I have a person that's not hyperinsulinemic, fasting sugar is good, they're just 20 pounds overweight, that patient's going to lose weight very rapidly. Okay. My patients that are hyperinsulinemic, or God forbid diabetic, I've got to correct those abnormalities before they're probably going to start losing dramatic amounts of weight. So it's all about giving my patients proper timeframes, because where you will lose patients in weight loss programs is, oh yeah, you'll lose weight in 2 months. Well, maybe they will, maybe they won't. Okay. And that's really important. So let's talk about goals real quick. Sorry, I made a new question out of this and added to it. Don't worry. But so I tell my patients that you won't start losing dramatic amounts of weight until we get to the dose that is right for you. So if I was seeing you, that might be the 2nd or 3rd dose. Okay. And we're titrating every 2 to 4 weeks. So potentially it might be 4 weeks, 6 weeks, 8 weeks before Leo is on the dose that I need him to be on. And when Leo tells me, I sit down to eat lunch, I'm not that hungry, doc, but I go ahead and eat and I get full so fast. And this is hard to explain to people that haven't been on semaglutide, but take how much you normally eat and just imagine if you ate half of that and you felt like you ate Thanksgiving meal is how these patients feel. And that is no exaggeration. They literally can't cram another bite into their mouth. So they walk away from the table full, fulfilled, and, feeling good. And when we get to that level, and if the labs are looking good, my women are typically going to lose somewhere between 5 to 7 pounds a month. My men are going to lose somewhere between 8 to 12 pounds a month. Unfortunately for the ladies out there, guys always seem to lose weight faster than women. It's just, I always say a not a good joke, but it's the way it happens. So I will then tell my patients, hey, look, it's going to take 1 to 2 months to get you to the level, most likely. And then I literally calculate, okay, they need to lose 30 pounds. So 5 pounds a month, 30 pounds, 6 months plus the 1 titration month. This is going to probably take 7 to 9 months to get you to goal, so that the patients understand it, because these programs aren't cheap. Semaglutide, even compounded, is not cheap. So I want to make sure my patients understand how much money they're budgeting for this. But what you will be surprised at is patients have tried anything and everything to lose weight and failed, and they don't mind paying money as long as it's a legitimate program that works, which this does. And then real quick to finish off the topic is, what do you do with patients when they reach goal? That's probably the most common question that I get. I've been asked it twice today by other providers. My patient's at goal. Now what do I do? Well, semaglutide is great for the brain, great for the heart. You can continue it long term. So like if it was you, Leo, and you're like, man, I've never been better, that my body fat is 15%, my muscle mass is good. What do I do now? Some patients will decide to do nothing, come off the product, and I'm good. Others, we will reduce the dose. We'll reduce it to like half and say, hey, Leo, take half the dose, keeping the cravings under control, keeping the appetite under control, but not suppressing it quite as much, because now we all know that maintaining is easier than losing, right? And so that's options. The third option is I say, hey, don't take anything, but if you gain 5 to 10 pounds, get your behind back into the office. Let's get you going again. So that's kind of how we approach it in our office. Sorry, that was a longer answer than probably what the question was, but that was a good topic.
No, very, very informative. And on semaglutide, how long can a patient stay on it?
Forever.
Forever. Okay.
So that's the great thing about it is it's fabulous data for totally has an amazing effect on neurodegeneration of the brain. Here, the fact that we treat a lot of people who are either at risk for Alzheimer's or dementia. I think semaglutide is an amazing peptide to use in those patients. Amazing data on improving cardiac function in congestive heart failure patients and others. So there is really no good reason why a person couldn't stay on it if they chose to.
Excellent. And this is a very interesting question. Are there truly helpful peptides that can be taken orally?
There are. Yeah. So again, most peptides, changing topics to peptides in general, most peptides are injectable. Okay. So, the vast majority are. There are a few peptides that are oral that I love. BPC 157, which is made in the gastric juices of our stomach, which can be injected or can be taken orally. I like BPC orally for neurodegeneration. I know we talked about that with semaglutide, but that's what BPC does as well. It can be very good for gut health. 5-amino-1-MQ, which is an NMT inhibitor, which basically helps with improving NAD levels in our body. Very effective oral peptide. Most peptides, though, are injectable. Those are the two off the top of my head that I would say that are oral that are very effective.
Perfect. And what would you say is the best way for someone to transition from semaglutide, from phentermine to semaglutide?
Yeah, so that one's always a tricky one. Okay. And so Again, I don't use phentermine in my practice, so I'm just going to put that out there. But I have had a few patients that come in on phentermine. Okay, so obviously you could stop them. I think that right away, but I don't think they won't be happy, right? Because they've been on the phentermine. I think that what I tell those patients is let's go ahead and get a couple of weeks of shots under our belt. And when they start to feel that appetite suppression, in addition to the phentermine, like a lot of times what happens with those phentermine patients is they'll go from like low appetite to no appetite. And then I'll say, okay, stop the phentermine and let's see what your appetite looks like in another week, because it gets out of the system pretty quick. So just a transition, if you're comfortable with the phentermine, if you feel like it's safe in that patient, keep it going for maybe a couple of weeks to a month. Transition them. The problem that you may have is phentermine also it's a stimulant. So some of these patients are what they really like from the phentermine is that stimulant effect, which you do not get from semaglutide. There's some practitioners, not me, but some practitioners that combined phentermine with semaglutide. I don't like the side effect profile of phentermine, and so it's just not something I use in my practice very often.
Fair enough. Thank you again for taking all of the questions and answering them all. Again, to the viewers, if you do have any further questions, we do ask that you email them to learnmore@accessmedlab.com. The video will be posted on our YouTube channel as well. Dr. Kris, again, thank you so much for joining us tonight. Thank you, everyone, and we'll see you next time.